Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. My guest today is Matthew Anastasi. He's the CEO of Limina Sleep Consulting.
Right.
He's been in the field of sleep medicine as a manager, sleep technologist, author, researcher, conference organizer, and a volunteer for 20 plus years. So Matt, thanks for coming. How are you doing?
Oh, it's good to be here with you, Rich, especially now that March is Sleep Awareness Month and we're still coping with the start of daylight savings time. Sleep is the topic on everybody's mind.
Actually, maybe we could start with that. What is the effect of daylight savings time that you've observed on people's sleep?
Well, I happen to have a 2-year-old, so it's had a big effect on her routine because she sleeps like clockwork. So if we try to get her to bed a few minutes off of her circadian rhythm, she has a lot of trouble with that. So in advance of the start of daylight saving, what we did was we started advancing her bedtime just to get ready for that day. And kind of it did help, but she's still adjusting a week later now. As far as I'm concerned, yeah.
I mean, I guess some people would say, oh, it's just an hour difference, but does it have a huge effect if it's not handled right? Like, how do people typically handle it, and what does it do to them?
Yeah, so there's two processes that determine if someone's feeling alert or feeling sleepy. There's process H, which is the homeostatic drive. So this starts weak the minute you wake up in the morning, and it starts to get stronger and stronger throughout the day, the longer you go without sleep. So process H, the drive for sleep, it's just like thirst or hunger. The longer you go without it, the stronger it gets. But the other process that's taking place at the same time is the clock. So the circadian process C, the circadian clock, is actually embedded in every cell, living cell in our body. So every cell in our body, if you were to separate it from the rest of the body, knows what time of day it is. And when you change that, even by 1 hour, has a huge impact on basically the function that each cell has throughout the circadian rhythm. So circa, or of, about in Latin, and dia, or day. Every cell has a different purpose and a different function depending on what time of day it is. For example, in the afternoon, we're recording this now at the circadian dip between 2 and 4 o'clock is when a lot of cultures have their siesta, and it's among the lowest alertness times of the day because you have a buildup of the homeostatic drive, which is pushing down your alertness, and you have a really weak part of the day for the circadian drive, which is the alerting drive.
Okay.
Yeah.
So what do you do at your sleep consultancy? What's some of the main types of people that you see, and what do you do?
Well, I took sort of my experience in the first 10 years in my career. I did research, and then the following 10 years I was on the clinical side at major teaching hospital health systems, and I kind of put those two together and started Limina Sleep Consulting to provide a variety of sleep consulting services for those companies looking to put forth evidence-based best practices. So sort of the first part of what I've done in the new era of affordable care. So in March, we're coming up on the 10-year anniversary now. March 23rd, the Affordable Care Act was signed into law by President Obama 10 years ago to that day. And that has not only had a huge impact on healthcare, but sleep specifically. So companies that I've worked with, we've really created a lot of lessons learned from putting ourselves at the forefront of changes in healthcare as far as sleep is concerned. And I'm starting to put that into practice with, just my company and some of my approaches that I take. For example, I provide expert strategic analysis for companies that are investing in the industry of sleep. I provide conference organization and lectures for sleep professionals who are trying to stay ahead of changes in sleep. And that includes continuing education content, article and book chapter authorship. And I've also been giving some insights and support for industry sales and marketing areas as well.
So, all right. So what's an example of some of your work, I guess, on the particular, maybe not the company side, but with dealing with individual people or groups, or the advising side? Like what are some of the big issues today in sleep in terms of care and where they're lacking?
Well, the affordable care has had an effect on sleep as basically changing it from a fee-for-service operation to the current environment where providers are now being graded on how they can improve patients' quality of life, reduce exacerbations, reduce expenditures. And it's not just providers that are impacted. Insurance changes have shifted the economic burden to patients as well. So for the providers themselves, the field of sleep medicine, specifically with sleep technologists and a lot of the hands-on clinical care that takes place, it's, when I got started in the field 20 years ago, this was mostly an on-the-job training type of a field. So if you were a respiratory therapist working with sleep patients or a sleep technologist working with sleep patients, you learned on the job. And that made it more of a trade at that time than a profession. And what we've seen is that it's transitioned dramatically because insurance is taking the healthy patients and taking them out of the in-lab setting and putting them into the home-based setting. So they're getting portables, they're getting auto PAP treatment. And that really started to change around 2012 when Medicare released a position statement saying that those healthy patients without overlapping conditions that made their healthcare more complex could be diagnosed and treated at home. So what we're left with is really a sleep lab and a care environment where you have very high levels of acute patients, and that puts a lot of stress on the care providers like sleep technologists and respiratory therapists. So a lot of the content that I've produced has been, and a lot of the work that I've done has been on helping to raise that level of competency among sleep technologists and RTs, and help ensure that though they're being exposed to a lot higher risk situations, that they have the tools that they need to mitigate those risks and to still have a safe environment for them to work. So that would.
What are the challenges in the environment for the practitioners? Is it just too many people, or I don't understand?
Well, in the past, you would have kind of a mix of patients where you'd have real straightforward a sleep apneic who doesn't have any other serious medical condition, but that one serious medical condition. So they would come to the sleep lab, they would have they would just get titrated for using a CPAP machine, a constant positive airway pressure machine, and they would respond pretty well. Now you see on a typical night in a typical lab, you don't see those patients at all. So those patients have basically, they're getting devices that take the trained in-lab care professionals out of the equation. So what you're seeing in the lab is a really, you're seeing people with diabetes, contact precautions. You're seeing patients with serious mobility issues, cognitive issues, and these happen to be epilepsy. These happen to be the criteria that will allow them to be studied in a lab and excludes them from portable studies, from diagnosis and treatment in the home. So those are sort of some examples of patients that are in the lab. And in the past, if somebody, let's say, had a seizure, the response in the policy and procedures would be call a code and the study. So we're now broadening a lot of the testing that's done in the lab to be able to diagnose sleep disorders for patients using this example that have epilepsy, which means everything has to change. The sleep professionals need to be up to date on emergency responses. They need to have policies in place that accept a certain level of neurological changes in the brain and have sort of some responses in place in case there are those incidents. And what that allows us to do is if a neurology physician, let's say, is referring a patient to see if they have nocturnal seizures versus a parasomnia, where a patient is acting out their dreams, that's the type of patient we're seeing now, where we're treating those more what in the past were specialized cases, but they're the routine now.
All right. So what you're saying is the easy to solve cases now can be done with home tests or home treatment. So the harder ones are now going to the technicians, and that's why they need to up their game to know more to help these kind of people. Exactly.
And you're seeing even it transition even to CVS is now putting together a big outpatient push for the diagnosis and treatment of sleep apnea. And they're rolling it out in their minute clinics. So they have a couple thousand of these locations, and they're already selling devices, mask interfaces for sleep apnea, and they're using nurse practitioners to diagnose and write orders for those, and they're using portable studies. So you're starting to see it just become more available, which is a good thing, and streamlined. So they claim that they'll reduce the wait time from about 5 months to 8 days, which is a big claim. But anything that's going to reduce the time that patients wait from diagnosis to treatment is a good thing.
Why is it 5 months right now?
So just to wait, just to get in to see a sleep professional is 2 to 3 months. A lot of sleep labs are booked out. I would say 1 to 2 months. And then you have a period of time where the durable medical equipment company needs to be brought into the loop to get patients the device that they need. And then there's a 90-day period where you need to show compliance within that 90-day period for you have 1 month that you can show 4 hours a night, 70% of nights, to prove compliance in order for insurance to continue paying for a device. So there's so many steps that a patient can fall out of the loop, that even in the best case, the way it's set up right now, it's a period of months. which is unfortunate.
Wait that long. That's like,
Yeah.
So how will CVS, they'll just make this available right away? I mean, how do they speed it up to supposedly 8 days?
Well, that's their goal, and that's what they've claimed they can do. What I imagine would be involved, because it has not been rolled out nationwide yet, but from what I've read about it, it involves a portable study that you can take home in the Minute Clinic, and getting a diagnosis from those results would be from a nurse practitioner at the site. And then the device, the mask and the box, or the CPAP machine, it would also be available in the box at the site. So
would this make it any cheaper, or would this, I mean, it make it faster? I would guess it make it hopefully cheaper, but would the standard of care be high enough with a nurse practitioner versus like a lab study?
Yeah. Well, so that's been the talk sort of in my field, is that, even if you can reduce the wait time, there's a lot of problems with that model. So you're taking a whole field of very highly trained people out of the equation. So people, like, when you go to a sleep lab and have a sleep study, when you get a diagnostic study, which is just, attaching a bunch of wires, monitoring the whole physiology of a patient, you're picking up on things that a portable is going to miss. For example, a portable study generally doesn't even know if a patient is asleep. So most portable studies measure the times per hour that you stop breathing, but if it overestimates sleep or underestimates sleep, and it typically underestimates the amount of sleep, then it will show inflated numbers of apneic events. If it overestimates sleep, then it will miss a lot of sleep apnea. So that means that people who think that they're being people that think they don't have sleep apnea are out there, driving on our roads, and they're compromised. So there are a lot.
Sure, I guess it predisposes them to accidents and things like that, right?
Right. Yeah. Most people with sleep apnea don't know it. The American Academy of Sleep Medicine, they contracted a global research and consulting firm to look at this issue, and they found that 2 to 4% of the population has OSA, but only 20% of the population's been diagnosed with sleep apnea. And out of the diagnosed, only 50% are compliant with treatment, which is a case for having trained sleep professionals work with patients. And if you look at those figures, less than 10% of those suffering from sleep apnea are effectively being treated.
So what kind of an impact do you think that you're going to be able to make, over the next year or so?
Well, I've been working with a few companies to help them. For example, I'm working with a company that produces a line of all cloth masks, interfaces for PAP therapy. And most of their competitors, if not all, use a material that's made of plastic, silicone, which doesn't breathe, or memory foam. So this company, you may have heard of them. They're the Sleepweaver line of masks from Circadians. Okay. They're trying to get the message out, basically, about the advantages of their mask material over plastic masks. And that's a company where, just with the evidence-based messaging that we can put forth, connect that with sleep professionals, and do it in a way that puts their message out in front along with their competitors, will give patients a lot better options than they currently have. And there's a couple of scenarios where it's really important to have another option. Patients that are getting CPAP or BiPAP in the hospital setting, in the inpatient setting, are really prone to pressure ulcers. So this is an example where you're using a very lightweight mask that is breathable, where it doesn't, because of the construction of the mask, there's no moisture underneath it, so it breathes. It's lightweight, it's flexible, and it's a better type of mask for someone who's prone to pressure ulcers and skin irritation. I'm also working with RT Sleep World, and this is a company that does live continuing education webinars, on-demand CEUs, and articles, and professional conferences for sleep professionals, for respiratory therapists. And there's a lot of information that goes through that site to professionals that I'm helping with as well. We've been, I'll give you an example. There's been a lot of work done recently for positional obstructive sleep apnea. So just by design of the way diagnostic studies are run, a lot of patients, there's very minimal time where a patient can be studied while they're on their back, while they're in REM sleep, which is sort of the prime position and stage of sleep where sleep disorder breathing occurs. And the reason for that is that, there's a lot of split night studies, or really only partial studies, partial diagnosis, partial treatment, and very limited time where you're in that condition. And because of that, it really doesn't lend itself well to diagnosing positional sleep apnea. And there are estimates that patients with exclusively positional obstructive sleep apnea, in other words, if they don't sleep on their back, they don't have sleep breathing disorders. So either snoring or apneas or hypopneas, that subset of patients is up to 41% in some of the literature. So there's a range, but it is an estimate because it's hard to determine from polysomnography studies. But at the very least, patients with positional obstructive sleep apnea can really benefit from positional therapy, what's called. And there's been a lot of progress from the old days where positional therapy involved, taping a tennis ball to the back, and that, or just having a spouse nudge you. A lot of those approaches are pain-based, which aren't conducive to good sleep. But there's a lot of devices coming out now that are they're more on the nudge side. So they detect position, they detect what's going on audibly, and they'll use sort of a haptic feedback, the kind of vibration that you get on a cell phone in different measures from low to high, to prompt patients to move from their back to their side. So there's a lot of information that takes many years to develop in research, and then it takes many years to get out there through medical device advances, and also getting that information to patients and also to sleep professionals through continuing education.
Well, very good, Matt. So what's the best way for people to find out more about your consultancy and see if they need your help?
Well, I have a website, and it's called Limina Sleep Consulting LLC.weebly.com, and Limina is spelled L as in Larry, I, M as in Matt, I, N as in Nancy, A, Sleep Consulting LLC.weebly.com, and I'm also available at liminasleepconsulting@gmail.com.
Okay, well, very good. Well, Matt, thank you for coming on the podcast. I appreciate it.
Great to be with you, Rich. Thank you.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.